Hello, I'm Donald McCauley from medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in the US and I'm talking to Andrew Bazemore, Vice President of the American Board of Family Medicine. That sounds like a huge responsibility. Tell us about your career trajectory that led you to this role.
I came into medicine with a liberal arts background, really more of an undergraduate training in history and political science. Instead of working in a place like the U.S. State Department towards medicine that came through work in the early 1990s with a former minister of health in Bolivia, who unbeknownst to me was practicing something that Sidney and Emily Clark had called community-oriented primary care, and really showing how you could take a by the people, for the people approach to primary health care, merging public health, community medicine, stakeholder and grassroots engagement, and the primary clinical care that we know together, and take care of, in that case, about 28 villages, predominantly Quechua speaking, and some of the most indigent populations in a country that was the poorest in South America, and really achieve major healthcare achievements. And family medicine was the home that I found at University of North Carolina that most resembled what I'd known. I eventually added a public health degree, some work in travel and tropical and international global medicine, probably now 25, 30 years of going back to mostly Honduras. I often learn as much about how you can do the most with the least in primary health care as I ever have in the States. And eventually, after working in settings like community health centers and academics, was drawn to something that I had initially resisted: research evaluation, even policy, because it just didn't feel like I could go to work every day in the clinical setting that I was in. And frankly, a somewhat broken and fragmented health system without trying to work upstream and work on the bigger problems.
Before we go into the policy aspect, you've said something that's very interesting and kind of contrasts with many people's views of medicine in the US. And you've described your experience in South America as almost a socialized medicine. But that's a huge contrast to US healthcare.
One thing we've never done terribly well is collectively declare something as simple as primary care, basic or essential, I should say, in this case, healthcare, fundamental, a right, a social good. We have built a system around, our again, capitalist economy and a market approach, and really left higher level collective thinking out of many of our frontline implementation and systems. And so we spend an awful lot on healthcare, but as my VCU colleague Steve Wolf and the committee that wrote a mid-2010s report called Shorter Lives, Poorer Health note, we probably spend twice the developed nation average on healthcare per capita, and we lag in almost every major statistic, from life expectancy to healthy life years to quality adjusted or disability adjusted life years to how we perform across various chronic diseases, and even increasingly maternal infant child mortality, which are rising again. We're actually one of only 3 countries on the planet that have had 2 consecutive periods of reversal in life expectancy over the last decade. And the other 2 are a failed state, Venezuela currently, and one that's been embroiled in civil war, Yemen, for the last decade.
If we think about primary care and getting more doctors into primary care, I mean, that's another challenge. How do we create that workforce who are prepared to take that risk of working in primary care?
It's a great question. If you look at the U.S. primary care workforce, it is, by most estimations, a team sport in this day and age. Has been forever, though we've not always performed very well as teams or trained in teaming. And we've also created over decades an increasing gap between the highest and lowest paid disciplines, and among the lowest paid disciplines across fields perpetually, or the primary care disciplines. So whether you're a physician and you're comparing the general pediatricians, general internists, and family physicians that make up the core, not all, but the core of our U.S. primary care physician workforce, or a nurse practitioner, or a physician's assistant, or an allied health, the best way to use the same amount of training and achieve less lifelong return on investment or annual compensation is to enter primary care. We also need to change the composition to look more like our population, so more diversity and inclusion. We need to figure out how to take those who are trained, like family physicians, across a really wide scope and allow them to work to the top of their scope. And that's true for not just family physicians or physicians, that's for any of our trainees. And we do have to figure out a persistent maldistribution problem.
How can we change the policy at the top?
We need to look at national priorities, so stated, which include attendance from the 1978 Declaration of Almaty, where the nations of the world got together and said, primary care is the central feature of an effective health system. Full participation, universal access, affordability, all mentioned as components. After which we have gathered about every 10 years to say, again, primary care is at the center. We just haven't gotten there yet. That'd be the first. And in 2018, the nations of the world, including the U.S. Undersecretary or Office of the Assistant Secretary for Health, all gathered together and said at Astana back in Kazakhstan, we reaffirm the principles of that original Declaration of Almaty. We put primary care at the center of our health system. And specifically, we had an undersecretary state primary healthcare, PHC, which is really that merger again, as I mentioned earlier, of primary care clinical teams with community organizations and public health enterprises to affect population's health. The undersecretary said, this is what we believe in. We affirm this. We had a report that came out in 2021 from our National Academies of Science, Engineering, and Medicine on high quality primary care. And it wasn't just a rehashing of its importance. If anything, it looked back to another report, the 1996 Institute of Medicine report on primary care, and said, what didn't we do to achieve the goals and really the recommendations of that report? It created a roadmap and categories or 5 different buckets of recommendations. And one that was particularly notable, and I think notable right now, was the absence across a U.S. Health and Human Services series of agencies and bureaus of a primary care central council or feature or place where one person or a group of people at the secretary's level, like a Ministry of Health level, was waking up every day thinking about how do I advance primary care and primary health care, this integrative notion. And so right now we're having conversations about birthing just such a council, about having a permanent group at that National Academies of Medicine, the place that advises presidents and Congress on the direction that we should take our health system and its various features, that is dedicated to primary care. And implementing that, I think, is a critical first step. And from there, getting back to your conversation or your questions about workforce and payment and training and how we take public expenditures and use them to advance these various features, suddenly has a voice and a central voice. And then the critical element beyond birthing that is giving it some authority to help direct the health system's resources.
So in terms of policy and policy changes, one of the factors that drive policy change is data. And when you have office-based practice, which is very much the case in the US, how do you manage the data sets? How do you acquire the data sets?
Excellent questions. All in an age of what we've labeled big data. It's also notable that too many of our big data sets are derived from hospital and acute care and owned by hospital systems. No fault to the hospital systems. It just means you're probably not getting a full range of views and really of information emerging from the largest and most widely distributed component of your delivery system, primary care. So I think one thing that we've tried to birth at the American Board of Family Medicine is a registry, the PRIME, capital PRIME registry, to speak to the information that comes from caring for populations in small and solo practice in rural and underserved settings. Getting information from PRIME, from another group in Oregon called OCHIN, which is trying to capture info from the 14,000 safety net clinics, the federally qualified health centers. What's coming out of their electronic health records? Who's curating this? Well, OCHIN's at least taking a very laudable crack at that and turning it into meaningful research and research that informs policy. We have been very deliberate In our own group, it's trying to make the most out of not only claims data, our US Medicare and Medicaid, but also how we can integrate that and intersect what we learn from claims with what we learn from registries like the Prime Registry, and also a national survey. Go in and ask for any family physician in our board, and we see this across some of the other US boards, an ability to tap into what's happening in their practice, demographic, economic, and even questions about burnout come out of US family physicians, because we have, again, a unique opportunity every time they sign up to take their board certification or renew any of their board activities to ask them these questions again. And it gives us a veritable census on a serial rotating basis for US family physicians. And then you can only make so much sense out of large secondary data. So building out your qualitative resources. So not just surveys, but doing good informant and focus group information gathering has been the way that we round out what we think is a fairly robust series of data sets and sources of information on primary care. And in the US, I will say that this is a place that we've actually done fairly well. I've traveled enough to see that many other countries have not been able to build out as much of a robust network of information, particularly around primary care. But we still have a long way to go. Primary care is always the laggard. It shows up when we're doing artificial intelligence, machine learning work. We're trying to really understand how you can take large information and bring it back to clinical practice in ways that that new technologies and methods allow.
So we've talked about policy and we've talked about data, and there's a third pillar of primary care, and that comes down to the personal relationship, which you've written about as well. And that's a big challenge for all of us in primary care. And the two areas that you've written about are the continuity of care as one aspect, and the second is narrowing the focus from generalists, narrowing the breadth of practice. Where do you see those challenges?
So specific to continuity and comprehensiveness, since you mentioned those two, in the United States, we have, over the past 2 decades in particular, we have watched factors such as limiting work hours, a good thing for our physicians who were probably working too long and probably into spaces that weren't entirely safe. We've watched, a continued reductionism of the kind of work that we do. Primary care clinicians becoming hospitalists or laborists or pure outpatient specialists, if you will, begin to fragment a little of what we historically benefited from in a continuous relationship with patients. It is a bygone time where one single GP or family physician was able to see all of their patients in all of the possible settings of care. But there still needs to be some way to maintain at least team continuity and probably individual continuity using technology to our advantage. And we know from Starfield and other evidence that longitudinality, that relationship, that administrative record keeping that we're all able to hold in a primary care setting, it grows trust. It allows patients who are facing what they think are difficult decisions, whether it's about to get a vaccine or a certain lab test or not to get studies that they don't need, to have a single source of information that they trust over time. And while I do think that there is a personal and individual continuity that's valuable, in this day and age, it has to include the team. And to comprehensiveness, we have documented declines in both settings of practice, so working in hospitals or nursing homes or in emergency rooms and acute facilities in family medicine for years, doing less care of children, less care of certain types of diseases as we get more and more complex in our the range of things we're supposed to have excellent knowledge in. We haven't taken full advantage of technology, artificial intelligence, decision support tools, ways that a family physician does not have to singularly track all things about all aspects of knowledge in clinical primary care. Not put it to full advantage. We haven't taken full advantage of our teams again. And so we're beginning to lose this breadth, and we're narrowing in a space that doesn't benefit the patient or the populations we serve. It's pretty clear that those who have higher levels of comprehensiveness tend to have lower overall costs of care, tend to have more trust. The patients who come to those clinicians tend to value information across a wider range and, again, frankly, seek less undesirable or low value care tend to have less utilization of hospitals and ERs. So finding a way through teams and technology to retain the comprehensiveness of general practice, of family medicine or primary care is really crucial if we're going to bend our cost curve, maintain high value care for whole populations.
Now, there's something I must ask you, because despite this very important role in the American Board of Family Medicine, despite being at the top of the policy, you have worked with one of the legends of general practice in the UK, in the Outer Hebrides. Tell me a little bit about that experience.
You know, I'm so glad you brought it up. It was another a seminal and deeply shaping experience for me to work with Dr. John McLeod, a third-generation GP who worked out of Lochmaddy on the island of North Uist in the outermost Hebrides of Scotland, and really see what true continuity, comprehensiveness, coordination, and first contact look like. And that meant anything from with John driving the ambulance, sometimes an hour south to Benbecula, where we hoped the tide was out so we could get a patient with gallstones or, not necessarily an acute MI, but possibly some angina, some unstable angina off to Glasgow, or reaching the end of a day where we traveled all over the island, most of the work being outside of the surgery to take care of respite patients, and then put on our rubbers, got in the boat, went fishing, pulling up mackerel, haddock, crustaceans. And then my job as the med student was to make sure that all of the older community members who were no longer able to fish and who John worried about getting enough protein and good fish in their diets got a knock on the door from me as the med students, dropping off whatever we caught that night, and then inviting me back to his house, where he and his wife would break open a good bottle of Burgundy or Bordeaux and eat whatever was left. So really seeing what it looked like to do full spectrum general practice in a community setting as an icon. His longitudinality was 3 generations deep. He was using records that went back to his grandfather on some folks to do a truly unique form of what general practice can mean for populations. Fabulous experience. I'm so glad that we share that contact.
Finally, let me ask you about the future. And when we talk about the future, it seems a bit of a contradiction to mention personal care and artificial intelligence in the same sentence. Is there a role for artificial intelligence in good quality primary care?
I think absolutely. We've seen new technologies and what we've labeled disruptive innovations as somehow anathema to old-fashioned, comprehensive, coordinated, continuous primary care. Really and optimally, they would enhance that. Artificial intelligence, machine learning is a space that the ABFM is investing in. We think primary care should be at the table and not on the table, and should be part of designing fair and equitable algorithms that use data sets representative of real U.S. populations and all their diversity to answer questions that affect us on the front line, and not be further fragmented, not be cherry picking single elements of care away to apps or online services at the expense of, again, broad spectrum, comprehensive, continuous care. We think that if you use design thinking and proper engineering, and you create the kind of economic nudges that behavioral economics points us towards, you can use technology to enhance all of those 4 C's features and imagine a much brighter future for primary care. I'm actually optimistic as a generalist that my many deficiencies in an ever-expanding world of medical knowledge can be better covered if we design the right algorithms, we create the right training environments where we're incorporating new tools and technology, same as we have for centuries, to allow the primary care clinician to do more, to actually to broaden the scope. But we do have to start with, again, right technologic design, and we have to incorporate it in training.
Andrew, it's been fascinating talking to you, and thank you very much. But you said something that's really very interesting, and that's the importance of family medicine being at the table and not on the table. And US Family Medicine is really, really lucky to have you at the table. It's been great talking to you. Thank you very much indeed.
Thank you for the time and for the invitation. A pleasure talking to you as well.